I'm going to talk today about silver trauma and analgesia. And what I want to focus on the silver trauma side of stuff is looking a little bit about triage and the TARN report, because it probably won't surprise everyone to know that it's really tricky to recognise the older patient who does have quite severe trauma from fairly innocuous mechanisms of injuries. And we're going to just pick apart some of the key take-homes from the London Major Trauma System Elderly Trauma Guidance. And it's a really comprehensive document that looks at each of the areas that are relevant to our practice here at NUH, and probably just reflect a little bit on some of the good things that we're doing here as well. And then we're going to segue into the analgesia side of stuff. So for anyone who was at the M&M recently, where I presented an epidural-related case, some of this will be a little bit repetition, but we have recently updated our rib fracture analgesia guidance. So the real focus here is going to be on blunt chest wall injuries. Okay, so let's talk a little bit about why silver trauma is such a challenge. So there's 11.5 million people over the age of 65 in the UK. It's nearly 20% of the population, and it's the fastest growing part of our population. And come 2040, we're looking at a quarter of the population being over 65. So this is a problem that is only become bigger in terms of the major trauma burden that this age group will form. Now, I pulled a bit of data about what this means to us at NUH. So 75-year-olds who fell from standing presenting to ED, there were 22,000 of those cases last year. So these are humongous numbers. And if you look at all of the major trauma referrals from ED to the major trauma service, 75% of them are 75-year-olds who've fallen less than 2 meters. So this is the majority of our workload. And we need to identify the patients who have significant injuries early, rather than them being picked up a few hours down the line after they've been reviewed in majors in ED. Which brings us on to the 2017 TARN report, which looked at major trauma in older people. So probably the most important finding from that report was that every trauma system has difficulty in identifying early patients who have major trauma who are over 65. And when we fail to recognise them early in their journey, you get a lower rate of bypass to major trauma centres. So if we're not picking them up pre-hospital, we're not recognising them pre-hospital, they don't get a pre-alert, you don't get a trauma team, and their initial assessment and management will be not by consultants. And by delaying the identification of injury, giving them potentially suboptimal pain management and hydration strategies, this is all going to contribute to their delirium risk, which, as we know, has a massive impact on morbidity and mortality. And this is kind of where the silver safety net came from, which is a West Midlands tool that we use over in the West Midlands patch. It's not something we're using currently here in the East Midlands, but we do have an in-house alternative. So this is what the tool looks like. It's adopted by the West Midlands Ambulance Service, and there are certain triggers on here which don't sit necessarily on the major trauma tool. So this isn't replacing the major trauma triage tool in the pre-hospital field. If you trigger on the trauma tool, then you get a trauma call and you go to major trauma centre. If you trigger on this tool, then actually what should happen is you don't necessarily need a trauma call. You don't have to go to a trauma centre, but when you trigger on this silver safety net, the trauma units are allocating a queue for the patient to be received in. Now, I appreciate that in current stresses and climates, that's going to be very difficult to do, but this was a pre-COVID intervention. A middle grade would assess the patient on arrival as a priority, and they, in the forefront of their mind, they're thinking, do we need to activate a trauma team for this patient? And the idea being is they're trying to pick up patients who have major trauma injuries from innocuous mechanisms. Now, we do have a frailty assessment tool here at NUH, which is fairly similar, and it does allow our older patients to be assessed slightly quicker down an ED, but there's undoubtedly work that we can do to improve that. And perhaps part of that is with the pre-hospital triage system, and the pre-hospital silver or frailty triage group is being reformed now post-COVID, and it's one of the agenda items to discuss that. Okay, so that's the context of what we're trying to discuss. This, I've hopefully painted a bit of a picture as to the workload that this cohort of patients is causing. Next, I want to talk about what the Pan-London silver trauma guidance looks at. There are actually very few national guidelines out there on focusing on the needs of the injured older patients. And I would advocate having a look at this guidance if you have some time. I'm going to go through some of the executive summary points now. Okay, so there's a few bits that are the key take-homes really. Not unexpectedly, not just the age, but also the comorbidity status and medications patients take impact on how they present, not just from an injury perspective, but also our assessment of their physiology. As I've stated already, you can get quite significant trauma from fairly innocuous mechanisms of injury. We need to be thinking about anticoagulation reversal on arrival in ED, and I'm going to talk about that in a bit more detail later because it's particularly relevant for rib fracture patients. Now, this is one of the values of working in a major trauma centre where we have access to major trauma wards. The early involvement of therapists, physio, occupational rehabilitation, orthogeriatricians is fantastic here, and that's undoubtedly having a positive impact on the outcomes, and probably one of the main reasons why the major trauma network has improved outcomes from older trauma so significantly. And then the fifth point is really important, I think. We need to recognise futility early and palliate appropriately. It's not fair on families, patients and the wider team to resuscitate all patients with the same aggressive nature, irrespective of their injury threshold. So we need to be thinking about these discussions early, and an early consultant involvement across multiple specialties is required. Okay, so let's go get a bit more clinical and look at some of the key areas to talk about. Okay, so in terms of ED, patients should have a full assessment of concomitant issues, any other exacerbations of comorbidities. They need a full workup, including postural blood pressure, ECG, chest X-ray as appropriate. I appreciate a lot of these patients will be spinal immobilized. We need to be thinking about DNA CPR decisions in ED in discussion with patients and family. They shouldn't be going to the ward without these discussions happening. Unless it's absolutely necessary, either due to the injury that they have, hemodynamic instability or urinary retention, we should be avoiding catheters at all costs. We know that they increase infections, delirium and length of stay. Before patients leave the emergency department, we need to assess their spinal and pelvic stability, and there needs to be a documented decision from the relevant specialties about what immobilisation is required on the ward. Prolonged immobilisation of the older patient always leads to increased morbidity and mortality. And of course, safeguarding considerations. And this sometimes gets forgotten. I think we're pretty good at safeguarding considerations for children that come in as a major trauma case. I suspect sometimes we probably forget when it's the older person, and it's just as relevant. Okay, so just a little touch on the major trauma wards. It's a really fantastic multidisciplinary assessment that patients get on C30. They get input from a wide variety of specialties, and even the board rounds in the morning have nursing staff, physios, occupational therapy, rehabilitation, surgical input, and sometimes acute pain from the outset. And if you have a chance to go up to the C30 and see what they do, it's really worth doing so. And this is probably what makes the main difference in outcomes that we've seen with the introduction of the major trauma network, is this holistic approach to major trauma care. It's probably not the Gucci resuscitation stuff in ED. Yes, that helps, but the majority of it's going to be this stuff. Okay, what about older patients with neurotrauma? So we have a lower threshold for CTing their head. We repeat the CTs with a pretty low threshold, particularly if they're anticoagulated, and we need to be reversing their anticoagulation within an hour of arrival. Now, this has become somewhat more challenging with the increasing frequency by which patients are anticoagulated with DOACs, but I'm going to cover some of that in a few moments. Okay, so we've touched on this already, but let's just focus on cervical immobilization, because most patients who come in with major trauma will have their spine immobilized as a default. It's really well documented cases of worsened neurological outcome with poorly fitted cervical collars, particularly in the older patient with pre-existing kyphotic disease. You have an increased risk of a wide variety of complications if you immobilize older patients for a prolonged period of times. And with that in mind, we should be aiming to have a MSK reported CT imaging of their spine within 2 hours. And if they need prolonged immobilizations, you've spoken to the spinal team and you haven't been able to clear their neck for whatever reason, then we need to be switching to a padded collar before they go up to the ward. So a Miami J or an Aspen collar. We need to be getting patients off those Furno orthopedic scoops that they come in pre-hospital with as soon as possible. And in my opinion, we should be de-scooping them before they go to scan. That does require us to have access to a trauma mattress for when we receive these patients in ED, and we have a temporary hiatus in access to those, but they are coming back. So please, when they do come back, don't scan patients on scoops, get them off that hard scoop as soon as possible. Okay, pelvic injuries, a bit more straightforward. If you suspect a pelvic fracture, you need a trauma team, you need to resuscitate them as per national guidance. Be careful about having binders on for more than 12 hours. I mean, it can be done and we certainly do it, but we should be looking to fix their pelvis if it's unstable injury as part of their damage control surgical approach. And if you're concerned about a pelvic injury in the older patient, scan them top to toe, because it's likely that there'll be other unrecognized injuries, and NICE would support that approach. Okay. Let's focus a little bit more on chest injuries, and we're going to go into the rib fracture guidance in just a few moments. Not unsurprisingly, elderly patients with blunt chest wall injuries and bony injuries have a higher morbidity and mortality. We need to CT them. Chest x-rays are out. They're poor sensitivity, as you know. A small proportion of these patients may benefit from operative chest wall stabilization, and we're going to talk in a few moments about what our departmental guidance is for this and what the research is being undertaken at the moment in this field. We need multidisciplinary input from the outset. We should be these patients should be referred to us as anaesthetists from ED for pain or epidural consideration, and we need physio and OT input on major trauma wards. And it's really ribs 1 to 7 that cause the most problems. They're the ones that are most important from a ventilatory perspective. 8 to 10, although can be sore, you don't tend to get as much ventilatory dysfunction with those injuries. So what do we do when these patients come in anticoagulated? Well, there's a few options for us. Orphan's pretty straightforward. We just give Octoplex. It's NICE approved. It's in license, it's easy to do. We just need to speak to hematology to get access to this. It's the 10A inhibitors, the DOACs, that are more problematic. So Adexanet alpha is a reversal agent available for rivaroxaban and apixaban. It's not NICE approved, I don't believe, at this stage, or licensed in the UK. It is FDA approved. You can get access to it for patients with upper GI bleeds fairly easily, in my experience, but I've not really had much success in getting access to it for major trauma-related bleeding or reversal of anticoagulation for epidurals. An alternative for partial reversal of these DOACs is to give prothrombin complex and a dose of TXA. So you keep that one in your back pocket for when you need to do something quickly to get some reversal. The 2A inhibitors, so your dabigatrans, we have a NICE approved reversal agent. So remember that, because occasionally these patients come in and we can get access to Praxbind to reverse dabigatran pretty quickly. It's easy to forget that we have access to this, but it is a lifesaver. Okay, so let's look at the acute pain guidance for these major trauma patients with blunt chest wall trauma. So opioids are almost universally going to be required in the first instance. There are different routes in which we can administer them. If you're going to go down the PCA route for patients with chest wall injuries, please use fentanyl. It is what the trust guidance now advocates, and its pharmacokinetic profile is much better for a PCA approach. We can think about opioid-sparing agents such as gabapentinoids, ketamine. Lidocaine, the jury's still out. Research is equivocal. It's probably fair to say. We're working on looking at some trust-based guidance on this, but it's not available as an option yet. But regional anaesthesia is what we should be thinking for all of these patients from the outset. And the new rib fracture guidance talks about how we can risk stratify patients and think about who needs these blocks early before they deteriorate. Okay, so just to recap some of the stuff we've been talking about before and bring it into a more closer context for NUH, nearly 40% of major trauma patients here at QNC have rib fractures. If you're over 65, you've got twice the mortality if you've got rib fractures than someone who's under 65, and every rib will increase your mortality by 20%. So it's a problem that we need to be thinking about early as they arrive in ED. Flail segments in particular are very dangerous. So there's a subtle difference between a radiological and a clinical flail in terms of the definitions. But if you can see a flail segment from the end of the bed, then your mortality is nearly up at 35%, irrespective of your age. So it's a really dangerous disease to have. And those patients either need surgical fixation of their rib cage, but they absolutely need an epidural or some other regional technique to analgesize them as soon as possible. And they often need intubating and ventilating at the point of arrival, if they haven't been already by the pre-hospital team. Okay, just to go through a few of the complications, and forgive me, this is going to be teaching the vast majority of you to suck eggs, so bear with me, but there's a relevance to what I'm going to talk about here. So in terms of things we can expect, well, pre-hospital, we look out for things like hemopneumothorax, but ventilatory dysfunction from either pain or a mechanical disruption of the chest does present really early, often before I've even arrived to these patients on scene. So analgesia is absolutely paramount. You've got to analgesize these patients quickly and effectively if you want to differentiate hemopneumothorax or mechanical chest wall ventilatory failure from pain-associated ventilatory failure. And the same is true for the patients who have pulmonary contusions associated with their rib fractures. The hypoxia that they can present with can be mitigated quite significantly by early and effective analgesia, and fentanyl is what I would advocate on their arrival in ED, judiciously administered, but to the point at which you've taken the pain away, and then you can reassess their physiology to determine if they have ongoing ventilatory dysfunction. So the BJA education has a fantastic piece looking at rib fractures, fixation and analgesia. And they talk about the meta-analysis that was done in 2012, looking at risk factors for morbidity and mortality in rib fractures. If you're over 65 or you have 3 or more broken ribs, your odds ratio of mortality is 2. So you've got twice the chance of dying. So those are the most important factors. You want to pick out the patients in ED who might look okay now. They might even be able to deep breathe and cough, but if they're over 65 and they've got 3 or more rib fractures, we really need to be thinking about putting an epidural or an alternative regional technique into these patients before they deteriorate. So what do we do, or what should ED be doing for these patients as they arrive? Well, simple stuff to start off with: oxygen titrated, humidified if possible, early analgesia. And if we're involved, I would advocate giving fentanyl to get them analgesed quickly. And let's do a risk stratification score, because this will allow you to pick out those patients who need an early intervention who might currently look okay. The analgesia guidance for the trust: simple analgesia, non-steroidals as tolerated depending on their risk profile. If you're over 70 or you've got renal failure, it's short tech, long tech. If you're under 70 with normal renal function, it's zoomorph, oromorph. Please prescribe regular laxatives and a regular antiemetic. Now, it's not actually my practice to prescribe regular ondansetron. It has it can cause constipation, which is obviously going to contribute to the opiates. The trust guidance does advocate it, but think about alternatives such as prochlorperazine as well, if appropriate. Okay, so this is the risk. This is why risk scoring them is so important. This is in our new guidance. The green is your low risk score patients. And if you're kind of in the nearly orange category or nearly yellow category, do look for whether or not they've got any other risk factors that would push them up. Okay, but it's these patients in the score 16 to 30 that we need to really think hard about. If your patient has a score of 20, let's say, on your stumble score, they can deep breathe and cough, and they're 72. We need to be thinking about putting an epidural or an alternative block into that patient before they deteriorate. Because what tends to happen is that they'll get dehydrated, they won't drink much, they're not going to move about, they're going to retain secretions. Their reassessment of the pain score is going to show that they're deteriorating. We put an epidural in 12 hours later, and they don't tolerate that sympathetic block very well. So we need to get these epidurals in early. And of course, anybody that's particularly high risk needs to be discussed with critical care, if appropriate, based on their other injuries and comorbidities. Right, we're going to talk about rib fixation later, so I'm going to skip through that bit. You don't need to read this slide. The point here I'm trying to make is that you can make an assessment in the ED, but they need to be reassessed every 4 hours. Now, that doesn't necessarily have to be by us or the pain service, but these patients deteriorate really quickly. And if you've got suspicions that the patient has a high stumble score and you've decided that they're not warranted for an epidural yet, please put a plan in place for them to be re-reviewed, because they may need one within the next 4 to 6 hours. Okay, so the guidance also has a decision-making tool about what type of regional technique we can offer these patients. So look, the take home is that a thoracic epidural is the gold standard for severe and bilateral chest wall injuries. It reduces length of stay, chest infections and ventilatory days when you compare it to systemic analgesia. And it is superior to other regional techniques and meta-analyses. So I don't want anyone to take home from this talk that we shouldn't be putting epidurals in. We absolutely should for the right patients. But if the patient can't sit or roll, or an epidural is contraindicated and you can't reverse the anticoagulation, then we do need to think about alternative regional techniques rather than just starting a fentanyl PCA. And these regional alternative techniques might be a bridge to epidural therapy. For example, we need to wait another 24 hours for a DOAC to clear from the patient's system. Or it might be that we need to undertake an alternative technique, and then if that fails, the risk benefit tips in favour of us doing a higher risk epidural later on. So what techniques do we have available? Well, there's probably 2 main ones we need to talk about. There's serratus anterior plane blocks and there's erector spina plane blocks. Now, if the patient can't sit or roll, so you can't access their back, then a serratus is what you want to do. If they can sit or roll, but the rib fractures are anterolateral, then a serratus will still work. If the rib fractures are more posterior, then you want to do an ESP. If you're going to do a serratus or an ESP, please put a catheter in rather than doing a single shot block, so that we can start an infusion of local anaesthetic. And the new local anaesthetic infusion guidelines for the trust to have a section for ESPs and SAP catheters, and the pumps can be programmed appropriately to deliver higher rate infusions for these fascial plane blocks. But if you get a poor effect from any of those, then we will progress to an epidural for some patients. So next we need to think about how and when we should reverse the anticoagulation. So again, in the guidance is a tool to help you make that decision. So a risk-benefit decision tool. So if they've got severe trauma, they're still bleeding, they've got multiple rib fractures, you think they're going to do really badly without an epidural, and they're low risk for thrombotic event, then it's pretty barn door that we need to reverse the anticoagulation. And of course, you know, the opposite is also true. If they've got 2 rib fractures and they've got a mechanical mitral valve, for example, then we might be more reluctant to reverse the anticoagulation. But most of the time, the decision isn't straightforward. And we need to consider all the risks and benefits, and perhaps have a multidisciplinary consultant level discussion about who we are and aren't going to reverse. And then in collaboration with hematology, as I said before, if they're on a DOAC, you can use prothrombin complex and TXA to get some partial reversal. And if they're on dabigatran, don't forget about Fraxbind. Okay, some of the expectations from the new guidance is we want patients well analgesied within 5 hours. Okay, and this is really difficult. We would like an epidural sited within 6 hours of referral. And I think the only way we're going to get even close to this is if, when you attend a trauma call, you see a patient who has multiple rib fractures who you think is going to need an epidural, please consent them when you're in ED and book them before you leave the department. That way they can come up to theatres for their epidural on their way to the ward. If we don't do it in that order, it's often 12 hours before we get to them. And that's when patients start to have really bad reactions to sympathetic blockade if we've waited too long. If we want to fix the ribs, we need to do it within 48 hours. So let's talk a little bit about fixation before I bring this to a close. So NICE does advocate rib fixation for flail chest requiring mechanical ventilation. And they have shown in the TARN studies that you reduce your ventilator-associated pneumonia, tracheostomy rate, hospital length of stay, ICU length of stay, and mortality in that cohort. There are other indications that are advocated with a weaker evidence base at the moment, such as severely displaced fractures, failed ventilator weans, and the non-flail study that was published a few years ago did demonstrate that if you've got 3 or more displaced non-flail rib fractures, you can reduce your 2-week pain score, opiate consumption, and improve quality of life. But there are multiple larger RCTs ongoing at the moment, the OCTS and ORF trials, that will probably paint a much clearer picture about who we should and shouldn't be fixing early. But what TARN does advocate is that we need to fix them within 48 hours, really. And if you're getting to 10 days, there's probably no benefit. And that's relevant when we come to think about contraindications to these cases, when we go to pre-assess them for their fixation. This is our trust guidance at the moment. A patient who meets any of these criteria will be referred for surgical fixation if they aren't part of the ORF or the OCTS trial, which we're running here at NUH. So this is probably going to be updated once the trial results come out. Okay, for the trainees listening, this is a great topic for the FRCA. I've just taken a few key learning points out from a BJA education article that looks at surgical rib fixation. So what are some of the contraindications to fixing these ribs? Well, if they're going to be ventilated for a protracted period of time for other reasons, and you're going to get anywhere close to that 10-day mark, then actually the benefit of fixing the ribs probably isn't held up by the evidence base. Any pathology that doesn't tolerate one lung ventilation, so big brain injuries or ongoing respiratory failure, you need to be cautious about. However, it's really unusual for us to do these fixations on one lung now. We tend to do them with a standard tube and 2 lung ventilation. So that's a relative consideration, I think it's fair to say. And of course, any systemic sepsis, you're putting metal work in the body, you need to think carefully about that as well. You're going to need CT 3D recon. And when I previously gave this talk, I didn't think I'd ever have to really think about that much. But of course, when we had those IT failures recently, that became a problem, and we had to cancel a case because we couldn't access that. And we tend to only fix ribs 4 to 9. They're the ones that are most painful, the ones that are most important for ventilatory function. Keep in mind that ribs 1 to 3 are pretty well splinted by your shoulder girdle and pectoral muscles already, and 10 to 12 don't have as much ventilatory function. So you don't need to fix all of them, is what I'm saying. You just need to fix 4 to 9, really. Okay, and if you get asked in the FRCA how are you going to anaesthetise these patients, these are the kind of things you need to think about. So from a pre-op assessment perspective, they haven't just got rib fractures. We need to almost treat them like a fresh trauma call. What did the pan CT show? Have there been any addendums to the CT? Who's reported it? What's their current physiology looking like? Look for extrathoracic injuries and how that's going to impact our care. And either they're going to have respiratory or cardiovascular compromise, which we need to balance against the risk of this anaesthetic and procedure, or they're going to have other types of injuries that are going to limit our ability to position them appropriately. For example, unstable spinal or pelvic injuries. A lot of these patients already have a pneumothorax and an intercostal drain in, but if they don't, you need to have a brief with the surgical team about what's the thresholds are going to be for the recognition of a developing tension pneumothorax under positive pressure ventilation in theatre, and who and how are you going to manage that. I've had a patient who we were fixing the right side of the chest and the left side tensions, and we knew it was a risk because there was a small pneumothorax there which didn't need treatment at the time, and we had a brief about who was going to do the finger thoracostomy on that side to manage that should the patient deteriorate. So you need to think about these things. But if they've got a drain already, that drain will be taken out and they'll have a chest wall defect, which will allow any decompression. So of a pneumothorax, that becomes less of a problem. In terms of intraoperative considerations, so tend to do them supine or lateral, but again, think about unstable pelvic or spinal injuries about if you're going to position them. I haven't done one on a one-lung ventilation strategy. They've all been done with a standard tube, but you might need to put a double lumen down depending on the surgeon preference. We've talked about pneumothorax considerations and having a plan in place about how you're going to manage that should they deteriorate. And they don't all need to stay intubated post-operatively, particularly the ones who weren't intubated pre-operatively. So have a little think about what your analgesic plan is going to be. And I'd advocate just doing what you would normally do for elective thoracic procedures. Most of these patients are going to get an epidural if they don't have one already, and putting an epidural at the end is pretty standard for my practice for these cases. That's all I have to say today. Thank you for listening. Quite a few references this time, which I'll just leave up for another second or two if anyone's interested.